Hey everyone. So today, right now, I'm going to talk about space maintainers. So why do we need space maintainers and when should we do it? Uh, so in few cases, when a patient comes, we always try to save their baby teeth. When we cannot save them, then in that case, we have to predict when the permanent tooth is going to come. And I have placed um, I have placed in one of the slides the chart when a tooth sheds and when a permanent tooth will come. So it's, I think, the third or the fourth slide in this PowerPoint, and you'll see it. That will help you determine whether the tooth, whether we should do a space maintainer or not. So it's premature loss of baby teeth can cause problems in eruption of permanent teeth, which means that if the baby teeth fall early and then the permanent teeth, it's going to take 2 years before the permanent teeth is going to come in that space. What happens is the first molar, it has already erupted, right, at an age of 6, or the other deciduous teeth, the teeth start kind of shifting, drifting, tilting, and the space gets decreased for the permanent tooth to come out. And that's what we don't want. So that is the reason we do space maintainer, that's we want to save that space for the permanent tooth, and we do the space maintainer. Now I have attached few links for space maintainer, which please definitely you guys need to watch, because that's going to really help you guys to understand what a space maintainer is and what kind of space maintainers we do. We mostly do a band and a loop. A band and a loop is pretty simple. We put a band on the posterior tooth uh, of whichever tooth the patient has lost. So suppose the patient has lost the second primary molar. Then we place a band on the permanent molar, the first molar, which has erupted. And then we put a band around that space, a loop around that space, and we do a band and a loop. And there is a video, a YouTube, which is there in the links. So please watch that YouTube. That should explain you pretty well about band and loop. Now, band and loop, you can do two ways. One is that you take an impression, send it to the lab will make the band and loop, and then you put it with glass ionomer cement. So you put the glass ionomer cement on the band portion and then cement it in the patient's mouth. The second is there are kits which come and you can make, the band and loop fit the patient's mouth. And I have done both. It's totally up to you. Obviously the one where you send it to the lab is a bit more expensive, but in few cases, if the kit is not going to work, then you have to send it to the lab. So that is about space maintainers. There are different other kinds. Now there is another one which is called distal shoe space maintainer. This is the one when the second molar, the deciduous second molar, is lost due to whatever reason, and the first permanent molar hasn't erupted. So in that case, we have to put something to save that space so the permanent first molar comes in its right position. So then we place the distal shoe space maintainer. Watch the video of the distal shoe space maintainer. It explains pretty well. Then there is another YouTube I have attached, which is explaining all different kinds of space maintainers. Now, let me tell you, in my 20 years of practice, mostly I've only used band and loop. I haven't used others that much. So band and loop is most common, and that's what we use most of the time. But you need to know somewhat about space maintainers for you to kind of let the patient know when they need it. Now we're going to talk about silver diamine fluoride. This is the latest thing nowadays. Everybody is doing it. I have to grab a paper really quick, guys. So sorry, but all right. So, okay. So silver diamine fluoride. It has been done in various part of the world for a long time, but in US it got approved now and we are doing it. It's safe in all ages. Actually, in COVID time, this is one thing we were doing a lot in our practice, especially when the kids would come, we would put silver SDF, and so we didn't have to use the drill, no air, nothing. So it was very good. So the advantage of SDF is that it is non-invasive. You don't have to need a drill. You don't have to fill, and it's great for non-cooperative patients. And few of the times I have seen that the parents a patient has a lot of cavities. Patient is uncooperative, right? And now I tell them, go take them to a pediatric dentist. They want to take them, but they don't have the finances, because even if they have Medicare, guess what? The insurance still charges them when they get nitrous or under GA. Patients, sometimes parents don't have that money. So the cavities are left alone and they're changing into pulpotomies and extractions and whatever sort of stuff. So in that kind of situation, the SDF works great. I mean, the patient is uncooperative. Just let the parents know that, we're going to apply this material. We have to let them know that it causes black stains on the teeth. But, it's going to basically stop the cavity. And at least the cavity will be stopped at that point. So in those cases, it works great. It's a 38% SDF, which we use. Make sure you always get a consent sign from the patient and the parents. And the disadvantage is that there is black stains and it has to be reapplied again. Also, you have to make sure you put Vaseline around the lips as well around this area, because if you get it on the skin, it's like a henna tattoo. So, once the skin has to grow back for the SDF to be out of their skin. So you just have to be very careful with its application. I have you attached a YouTube video how to apply it. It's very simple. Just dry that area with cotton roll or gauze or whatever. Then in the micro brush, you take the SDF, apply it, and then let it sit for 1 minute, and then basically you, that's it. Air it a little bit and then it's done. And then the patient will have to come again and you check that area and you basically see that there's no soft caries. So it's calcified basically. And then that's it. So you're all good with SDF. Please try it. Please try to use SDF on patients. It works great. Now, these are the charts I have placed, and I'm going to talk some clinical cases right now with you guys before we end this video. So let's talk about a patient who comes to our office. And this patient has a big cavity in his second molar, upper second molar. And this patient is 7 years old. And his first permanent molar has erupted. Okay, so this is a scenario where he's a 7-year-old male patient and he has a big cavity on his second molar, and his first permanent molar is there. What are we going to do? So first thing we are going to do is take an X-ray, right? And we have to ask the patient what are his symptoms. So what is going on? Why is he here? Is he just here for a checkup and we notice the cavity? or is it that it's been hurting him? So once we find out the reason, what's going on, we look at the x-ray, we look at the periapical area and all that, we start making our diagnosis. So now, if there is a periapical radiolucency, then and there is an abscess around the tooth. So remember, please retract the cheek and look around the gum area. If there is a bubble there, there is abscess, there is pus coming out of that area, then you know that the tooth is necrotic, and either the tooth has to be extracted or a pulpectomy has to be done. Pulpectomy means root canal treatment, right? Not pulpotomy. So there's a difference, pulpotomy and pulpectomy. So pulpectomy is root canal, where we're going to go into all the 3 roots he has and clean them up. Now in the primary teeth, if you guys have ever seen primary teeth, extracted primary teeth, these roots are very flared and they are long roots, like not too long, but they're flared roots and thin roots. It's very, very hard to do a root canal on these cases and for the root canal to be great. But if we want to, we can give it a try. So if we try root canal, it doesn't work, we have to extract the tooth because there is a periapical abscess. We don't want to leave a tooth like that in patient's mouth. He's 7 years old. Now, check what's going on with the second molar right here. It says it sheds at an age of 10 to 12 years, right? And so the permanent tooth basically is not going to come with, so the permanent tooth for the second molar is going to be the second premolar, which doesn't come till 10 to 12 years of age, right? So now we have almost at least 3 to 4 years that the second premolar is not going to come. So in this case, we are gonna try pulpectomy if possible. If the pulpectomy doesn't work, then you extract the tooth and then you go ahead and make a space maintainer. And most of the time I made a band and a loop space maintainer because the first molar has erupted pretty well. By the time we have done extraction and all, the patient is like 7 plus, it's fully erupted. We put the band on the first permanent molar and it's good to go. So that is a scenario in case of this. Now, now let's assume another case. Now, this one is going to be a lower tooth. Let's assume this is a first molar and this patient has a cavity and he comes and he says, I have a big hole in the tooth. When I retract the gum and everything, and this patient is 8 years old. And when I retract the gum, I see that there is no abscess, nothing, everything looks good in the, but the decay is almost close to the pulp of the tooth. So in this case, I can attempt to do a pulpotomy. So what do you do in pulpotomy? So I've attached a YouTube link of how to do a pulpotomy. In pulpotomy, it's very, very simple. You remove all the decay first. Okay, you want to place a rubber dam and control the moisture and everything. And after that, once you've removed all the decay, you want to make sure, like the second molar has 2 pulp horns. So you want to make sure that you extend the prep all the way to both the pulp horns and remove the dentine from that area. And then you go inside in the pulp. Now you're only going to the pulp chamber. You're not going in the roots. You go to the pulp chamber, there is some bleeding. You kind of spoon excavate it a little bit if you can. And then you put ferrous sulfate to stop the bleeding. Previously, we used to use formaldehyde, but now nobody uses that. So now it's basically just use ferrous sulfate, and then once after like 3-4 minutes, remove it if the bleeding has stopped. Then you use MTR, MTA, and then you can place zinc oxide eugenol filling, a thin layer, and then a glass ionomer or a composite, whatever works. So that's a pulpotomy. So do that. Now, then after few years, the same patient, he was 8 when we did the pulpotomy. And now his pulpotomy failed, and he has an abscess on that tooth, on the first molar, and he is almost 9 years of age. 9, and the tooth has started to get a little bit loose. The roots are kind of, then in that case, just remove the tooth, and you don't need to put a space maintainer. But because now, remember, the permanent tooth is going to be erupting very soon. And if it's kind of starting to get mobile, you don't have to worry to put a space maintainer in that case. I think that much. I think these eruption charts are going to be very helpful to you guys. Keep them handy because they will help you determine when to do space maintainers or not. And and that's about it. I think I am done with the pedo, and I'm looking forward to seeing you guys this weekend. Thank you so much. And I hope you all had a good week ahead of you.